Hi, Dr. Prakash, Manoj, Dr. Amuchou, and Aman, and I think there's Prakash Manikanti also.
Good evening, sir.
Hi, Surender.
कैसे हो?
Hello.
डॉक्टर प्रकाश को देखे बहुत टाइम हो गया. It has been
Hello,
so
good
many
evening.
years.
Good evening to everyone. All right, let's start.
Yeah, sure.
Hello, everyone. Hearty welcome to our state-of-the-art international webinar series in neonatology. Thank you for joining us today. Today, we will have an interesting discussion on a topic not so frequently discussed, the metabolic bone disease of prematurity. To moderate today's session, we have Dr. Prakash Vengal and Dr. Amanpreet Sethi.
Good evening, everyone.
Hi. Dr. Prakash Vengal is a senior consultant neonatologist and a director of Rainbow Children's Hospital, Bannerghatta Road, Bangalore. And Dr. Amarpreet Sethi, is assistant professor of neonatology at Government GGS Medical College, Faridkot. Today, we are going to hear from another doyen of neonatology, Professor Amuchou Saresham. Amuchou is a professor of pediatrics at Cummings School of Medicine, University of Calgary, Canada, and a staff neonatologist with Alberta Health Services, Calgary. He has been trained in various aspects of neonatology, including the perinatal epidemiology and the clinical epidemiology. And currently, he is the medical director for the neonatal intensive care unit at Foothills Medical Center and director of the target. He has some of the programs that he is directing, like the targeted neonatal echocardiography. He was a founding member of the SCAN workshop, which has become now very popular in a country in India. He is also the co-chair of Neonatal Restoration Program of the Canadian Pediatric Society. His main research interests include neonatal health outcome, neonatal hemodynamic studies, neurodevelopmental outcome, family integrated care, and perinatal epidemiology. His passions include teaching medical students, residents, and health professionals. He has received many awards of excellence for his teaching. So, we have a great speaker and two great moderators. So over to you, Professor Amuchou, for the lecture.
You guys can see the slide?
Yes, we can see that.
Yes.
Okay. Thank you very much for this kind introduction. And so without further ado, so I will just start this presentation. The title of the presentation is the Prevent Before It Breaks. I have chosen this title, over the years, we start seeing some of these uncommon occurrences of these illnesses, especially when we are trying to take care of extremely premature babies. So to start with, I'll just bring up a specific case. This was a preterm who was born at 25 weeks and 6 days. Birth weight was about 500 grams. It was a boy. Mom had severe pregnancy-induced hypertension. Therefore, she was delivered a bit early. Baby had complicated course during the NICU, including respiratory distress requiring ventilation for a prolonged period. He had spontaneous intestinal perforations in the first week of life, and he has been on and off TPN for about 6 weeks. And baby also developed cholestasis. So successfully, he was extubated after a course of DART, that is the dexamethasone therapy, and he was gradually growing. On day 65 of life, the nurses noted that this baby was unusually irritable. We're not sure he's on full feed, he's happy on his oxygen, but he was unusually irritable, and just noted a little bit of tenderness in the right leg. That's when the X-ray was done, and you can see the X-ray here on the right side. Especially, you can see there's definitely baby has got quite a lot of rarefaction of the bone, and you can see a subperiosteal bone deposition in the lower end of the femur. So this was the beginning of the presentation, and so we'll go from this. So based on these things, as we see, the learning objective for today are, first is to review what's the bone accretion during the early fetal as well as early postnatal life. Second is to identify what are the risk factors and what screening strategies are available for metabolic bone disease of prematurity. And third is, let's look at what's the evidence-based interventions to support bone health in preterm infants. So bone development first. So as we know, the development of the bone in the fetal life occurs in two specific processes. One is this, the osteoblast, which forms the osteoid, which is the organic bone matrix. And subsequently, there's the incorporation of minerals such as calcium and phosphate to this newly formed osteoid. That is the second phase of mineralization. So the bone mineralization essays start very early in the embryonic phase, but most of this mineralization occurs during the third trimester of the gestation. So if you look at how does these things happen? So first of all, between the mother and fetus interaction, so there's active transport of calcium, phosphate, and magnesium from the maternal circulation to the fetal circulation via the placenta. So because of this active transport of this calcium, fetus is in a what called the fetal hypercalcemic state, and calcium sensing receptors in the baby try to suppress the parathyroid hormone production in the fetus itself. And because of this, the baby has more chances for the calcium and the phosphate to regulate. Secondly, there's a calcitonin, which is normally produced by the fetal thyroid gland, helps also in the regulation of calcium and phosphate in the fetal life. So in general, what does it mean is that they have lower parathyroid hormone that helps in calcium and phosphate regulations and bone formation during the fetal life. They have very less amount of vitamin D because the parathyroid hormone itself reduces the functions of the 1-alpha-hydroxylase enzyme, which converts the vitamin D to active form of vitamin D3. That also happens in the fetal life. Therefore, mostly babies in a high calcium environment, but low vitamin D level. So as we can see that, so fetus maintains definitely very high mineral concentration compared to the maternal circulations. And fetal bone and mineral metabolisms are critically dependent on parathyroid hormone and the parathyroid hormone related proteins, but not too much on fetal intestine or fetal kidney for the vitamin D interaction. So in this graph, what you can see is that on the x-axis, it gives you the gestational age in weeks, and on the y-axis, the total body calcium accretion during the fetal life. As you can see that the fetal accretion of calcium slowly start increasing, mostly during the third trimester. The peaks is around between 32 to 36 weeks. So by the time the baby is a full term, it accumulates roughly about 30 grams of total body calcium, of which 80% of this minerals content came in the third trimester. If you look at the daily accretion of calcium in the fetal life, it ranges somewhere between 120 to 150 milligram per kilo per day of calcium. And the phosphorus accretion is about 75 to 85 milligram per kilo per day. So as you can see that if we are dealing with more extreme preterm or early preterm babies, especially before 32 weeks, they have less than half of the calcium and less than half of the phosphorus, which was accreted during the fetal life. So in the recent studies, this was from 2021, as you can see in this, you can also look at in the x-axis is by the fetal body weight compared to the how much is the total calcium accretions in the fetus. For a 500-gram baby, the fetal total body calcium is about 5 grams. It's pretty small. And as you go to about 1 kilo, it comes to about between 800 to 1 kilo, 8 to 10 grams. So there is quite a linear relationship of fetal calcium accretions as the birth weight also increases. Similarly, if you look at phosphorus, as you can see that by the time when the baby is about 500 grams, which will be roughly about 23 weeks, there is very limited phosphorus content in the fetus, which is about roughly about 2 grams. And by the time when you get to about 3 kilos, there will be about 15 grams of phosphorus is there in the total body weight. So therefore, knowing what exactly happens in utero and then what happens immediately after birth is essential to understand why metabolic bone diseases are common. So what happened after delivery? So this is a neonatal period. So after birth, so especially following a preterm birth, we know there's an interruption of those minerals which has been actively transporting from the mother to the baby. So lack of transfer of calcium and the phosphorus, that's number one. Number two is that as the baby starts breathing, there is an increase in the blood pH of the baby that itself suppresses the parathyroid hormone that results in the decline in this serum calcium and ionized calcium in the first 12 to 24 hours. So that may be one reason for early onset hypocalcemias are relatively common in premature babies. And therefore, most of us, as we are practicing in neonatology, you might see that lots of our babies do get, apart from dextrose, we get a little bit of calcium in order to prevent developing a serious consequences of hypocalcemia. Because of low calcium, as you can see, it starts acting on the parathyroid glands in the newborn period, which releases the parathyroid hormone. So parathyroid hormones, it acts on the bone and causes a resorption and release of calcium and phosphate in order to increase the low calcium. And that gives you rise to a negative feedback to the parathyroid hormone. Similarly, parathyroid hormone, it also acts on the kidney and activates the enzyme 1-alpha hydroxylase, which is important for the conversion of 25-hydroxy vitamin D to 125 hydroxylase, 125 vitamin D, which is again important for calcium and phosphorus absorption in the intestine. So during this process, overall, what it is doing is that it stimulates the bone remodeling and it causes increased bone resorption because of the high parathyroid hormone, thereby decrease the bone density. So that is the precursor for what we will be talking about, metabolic bone disease. Second other interesting fact is that whether a baby is supplemented with vitamin D or not, it does not interfere with the calcium absorption. So the intestinal calcium absorption in the first week or two is actually passive process, often facilitated by the presence of lactose in the milk. And prevention or correction of skeletal changes of metabolic bone disease can be done independent of vitamin D sufficiency. So, I mean, it's always a controversy about, how much vitamin D to supplement in order to absorb this calcium and phosphorus. But especially in the first 2 weeks, most of these calcium absorptions are being done through the lactose. So this brings to my first poll questions for the audience. Can we just get it? Manoj, you're able to?
Yeah. One second. Give me a minute.
Are we able to see?
I think they are able to see and they're answering. I mean, yeah, we'll see
Okay.
what is that.
All right. Okay, great. So I can see, so 40% says phosphate and calcium deficiency, 38 say mainly phosphate, 14 say mainly vitamin D, and 8 say mainly calcium. Okay, let's study. So, okay. So as we go through and come back to that answer, the answer is mostly the vitamin, the choice is D, the phosphate and calcium deficiency. Okay, so let's see how, okay, it's still going on, right? Okay. So just look at the terminologies, what we have used, right? There are various terminologies when we are talking about metabolic bone disease or prematurity. Sometimes we might use the metabolic bone disease. Sometimes we might use the osteopenia of prematurity, rickets of prematurity. Some people even use the osteoporosis or osteomalacia of prematurity. But so generally, when we talk about metabolic bone disease or prematurity, it means it's the undermineralization of the preterm infant skeletal from calcium and phosphate deficiency. And if the word osteopenia or prematurity basically means reduction in the bone mass in the absence of skeletal mineralization disorder per se. So sometimes we might just see the X-ray just look like, okay, it looks quite a low bone mass, but doesn't tell much about the mineralization process. However, when we talk about rickets or prematurity, it actually means it's the mineralization disorder arising from the lack of sufficient amount of calcium and phosphate, which may be vitamin D deficiency mediated, to mineralize the growth plate. That's why the word rickets are used in the neonate, because it's affecting the mineralization at the growth plate. In the adults, it's affecting the bone tissue. That's why we use the word osteomalacia in those contexts. So any of these three terminologies are often used in the literature when we are really looking at it. Which brings to my second question about how common is the metabolic bone disease in a preterm infant exclusively fed on mother's milk? Oh, this is the second. Can you just get a second, next question, Manoj?
This is the order in which I got. Okay. Yeah.
Okay. Yeah. I think I must have switched. Yes. So this is a question for how common is it in a preterm who isn't fed purely on mother's milk without any fortification? Okay, great. So 47% answer between 25 to 40%. Okay, let's continue. So early studies have shown that in an exclusively breastfed infant, the incidence of metabolic bone disease is up to about 40%. In the exclusively formula was about 16%. A recent multi-center study from China had shown, this was for babies less than 32 weeks, those who had exclusive breastfed, somewhere around 28% had evidence of metabolic bone disease. Then those who have 45 breast milk has about 20%. Then those who had preterm formula were lower, but the mixed group was about 20. So in meaning that definitely, yes, anywhere between 25 to 40% of infants who are exclusively breastfed in the preterm babies can develop metabolic bone disease. So why does the exclusively breastfed babies have bone disease? That's the next question, right? So this comes to the next poll question about what's the calcium concentration of human milk in this is the next third poll question. Then after that, we will just run through pretty quickly. Excellent. So about 60% of them said between 20 to 30 milligram per deciliter. Great. That's the correct answer. So this was the latest systematic review and meta-analysis of all the studies looking at what's the total calcium, zinc, and vitamin D in breast milk. As you can see here, that it's mentioned in a milligram per liter, so you can convert into milligram per deciliter. So it's between somewhere. So the mean calcium content of breast milk, both in preterm and term mother's milk, there are not much of significant differences. It's somewhere between 238 to 284 milligram per liter. You can see that. And as the breastfeeding duration increases, there's a slight decrease in the amount of calcium in the breast milk. Similarly, vitamin D content from, this was from roughly about 20,000 samples. The vitamin D content was about 58 international units per liter, ranging between 45 to 70. So meaning that, yes, the calcium contents are pretty low in breast milk per se. And moreover, as you have to remember that only 50 to 60% of the calcium which is enterally absorbed in our intestine. However, phosphate absorption varies anywhere from 80 to 90% in the gut. So to start with low amount of calcium in the breast milk, and then again, second is the absorption of that much. This is not huge. That might be the factors implicating for why exclusively breastfed babies and preterm babies may have high risk for metabolic bone disease. Similarly, if you look at the calcium and phosphorus, this was another meta-analysis done by my colleague here in Calgary, Dennis Fenton. You're probably aware of Fenton's growth chart. It's from Calgary. And Dominica, she was one of our pediatric fellow residents, did the meta-analysis and looked at the calcium and phosphorus content of breast milk. As you can see, we talked about calcium. So look at the phosphorus content. It ranges anywhere from 11 to 15 milligram per deciliter of breast milk. So, and it's quite similar whether you are a term baby or a preterm, and whether you are feeding in the first week or second week or later. So the total amount of calcium and phosphorus contents are quite similar between the two age groups. So which brings the point that knowing that, feeding is one important thing. What are the risk factors for metabolic bone disease and prematurity? So there are various antenatal factors such as placental insufficiency, preeclampsia, and choreo. Actually, they have effect, or they reduce the transfer of phosphate from the maternal circulation to the fetal circulation. Similarly, infants who have neuromuscular disorder, meaning that they are not doing much of the movement in utero. And those who have various genetic pleomorphism in vitamin D or estrogen receptors, they are at high risk for metabolic bone disease. In postnatal life, apart from being born premature, so you can see that those who are on prolonged TPN, because despite trying to optimize the nutrition, the calcium and phosphate absorption from TPN or the ratio is sometimes not able to achieve. So the prolonged, we give TPN, more likely they are at risk for metabolic bone disease. Similarly, infants who have BPD or NAC, as we know, lots of babies with BPD do get medications to control for fluid and then to extubate from the ventilator using a steroid. They also affect the calcium and phosphate metabolism. Similarly, infants with liver disease and renal disease are at risk for metabolic bone disease in the premature babies. So before we go to the next slide is that the pathophysiology, because if we remember the pathophysiology of metabolic bone disease, this might help in understanding what is the problem. So whenever, as we talked about, when you have calcium deficiency, either from lack of vitamin D or intake of calcium is limited, it decreases the ionized calcium. Ionized calcium stimulates the parathyroid hormone secretions. Basically, low calcium is the stimulus for increasing parathyroid hormone. As we have shown in the previous slide, parathyroid hormone causes bone resorption in order to mobilize calcium and phosphorus from the bone. This will appear as the osteopenia of the prematurity. Now, this calcium and the phosphorus which are resolved from the bone, basically calcium will be tightly balanced in the circulation, so they have normalized the calcium, but they start losing lots of phosphate. Therefore, low phosphate is the reason for seeing a rickets. You know, like we talked about this mineralization, poor mineralization in the growing plates of the baby. That's where the cause of all these fractures and everything. This also results in rise in alkaline phosphatase at the same time. Similarly, parathyroid hormone by the action on the kidney causes decreased excretion of calcium. Therefore, body is trying to reabsorb lots of calcium, but it increases the phosphate excretion. Therefore, hypophosphatemia is common when we have that. However, overzealous supplementation of phosphate sometimes can also decrease the calcium. Then the whole vicious cycle of hypocalcemia causing hyperparathyroidism, causing bone resorption and osteopenia and rickets continues. So when we are trying to talk about the management of metabolic bone disease, then we will come back to this slide again, just for a refresh. So what to do, right? So how do we diagnose metabolic bone disease? So there are various biochemical markers. We have urinary markers, then there are lots of radiologic tests. All are not perfect, but we have to use some of these things in order to apply during day-to-day clinical practice. Among the blood markers, we have often used our calcium, phosphate, and alkaline phosphatase, right? So calcium, irrespective of how low the body calcium is, when we measure the total body calcium, ionized calcium, usually we find normal number because already there is a body is trying to balance despite the calcium load. Phosphate is the earliest marker when you often see when we do a lab test for metabolic bone disease. So if you have a phosphate level of less than 1.8, so I think if you have to convert to milligram, it will be less than 5.6 milligram per deciliter. It often correlates with metabolic bone disease, especially in combination of rising alkaline phosphatase. In terms of alkaline phosphatase, the question often comes is, what's a normal number of alkaline phosphatase? If you remember, alkaline phosphatase initially start increasing in the first 3 weeks of life, then they peak to about 6 to 8 weeks of life. Just like, if I have to remember, it's like anemia or prematurity, you know, your hemoglobin goes down. But here, alkaline phosphatase start rising in the first 3 weeks, peaks by 6 to 8 weeks. The presence of alkaline phosphatase of more than 500 suggests impaired bone homeostasis. However, if you have more than 700 units, it suggests a bone demineralization. So if you are going to use a certain parameters, that is one way of looking at the trends of the alkaline phosphatase, especially in the first couple of weeks, is extremely important. We will talk about parathyroid hormone and vitamin D, which are like a secondary kind of testing because it's not easily available, not practical. It's not like our normal calcium where you get in a day. It sometimes from every center you might experience that it takes weeks for the result to come. So which sometimes is not feasible or practical in the NICU setup for managing acutely. However, if the parathyroid hormones is more than 70 to 100 picogram per ml, it's often suggestive of, seen in infants with metabolic bone disease. So we will come back to that point. So there are a few studies we have looked at. So Hung et al. Has looked at what's the sensitivity, specificity, as well as for calcium phosphate alkaline phosphatase. As you can see, this was based on the X-ray finding. Alkaline phosphate is about 700. You can see about, this is the area under the curve is about 80% there. But another study, when they looked at the alkaline phosphatase based on DEXA, somewhere around 650 is the peaks, but area under the curve is only 70%. So as I said, not individually, it's not very good screening test, but combination of ALP along with phosphate might be the way to look at. So ALP more than 900, phosphate less than 1.8, which is, as I said, 5.6 milligram, was 100% sensitive and 71% specific for reduced bone mineral content based on the DEXA studies. Second other thing is the secondary line of investigation will be a tubular reabsorption of phosphate. This is again important, but sometimes practically difficult to measure in various labs. This, along with PTH, might help you in differentiating whether we are dealing with calcium deficiency or a phosphate deficiency. So as you can see, the normal tubular reabsorption of phosphate is about between 85 to 95%. If a baby is absorbing more than 95% of all the phosphate, that tells, along with normal parathyroid hormone, and they have low phosphate, this indicates that the body is deficient in phosphate. So in this situation, phosphate supplementation may be a way to look at it. However, if you have very high parathyroid hormone and the tubular reabsorption of phosphate is low, in presence of normal kidney, that indicates we are dealing with primary calcium deficiency. So that is the second line of investigations when you are dealing with refractory hypophosphatemia or metabolic bone disease not responding to your usual treatment. In terms of radiology, so we have, I think in the NICU, most often we have is the plain radiograph. So in 1982, Crew's classification was used to assess the bone mineralization. So normal bone on the A looks like pretty well looking bone. Stage 1 in Crew's classification is just a rarefaction of the bone, just like here you can see. Stage 2 or is the bone end changes. So if you have metaphysis are having a cupping and fraying of metaphysis, which you often see in the rickets before it becomes fracture, or new bone formation. This is considered as a stage 2 of MBD from the Coos classification. Stage 3 is presence of fracture in addition to the previous findings. This is considered as a stage 3. This is a late finding. Even though X-rays are very specific for metabolic bone disease, but they are not very sensitive for early diagnosis of metabolic bone disease. Therefore, we cannot apply every baby. It needs at least roughly about 30 to 40% of bone demineralization has to happen before the X-ray changes to occur. So in a high risk NICUs or level 3 NICU where you're dealing with very small babies, people might suggest to, when you're doing your routine X-rays for chest X-ray for your BPD or abdomen, you can look at around 5 to 6 weeks of life. Just watch carefully what is happening to the bone, because that's the time most of our metabolic bone diseases start to appear in the radiographically. What about DEXA? DEXA has been used, but currently it is gold standard while we are assessing for bone mineral content in the research setting, because it's not practically feasible to do a DEXA in various NICUs. What does DEXA do, right? So DEXA expresses the calcium content of the bone per gram. The expresses hydroxyapatite in a centimeter square. So generally, the target sites where the DEXA are done are either you use in the forearm bones, or lumbar spine and calcaneus. And so the centimeter square, what you have applied and trying to see how much calcium content in that centimeter square is considered. So bone mineral density, more than basically, again, this is more on the research, because practically many NICUs, even in the advanced NICUs, we cannot use a DEXA. There are various operational challenges to practice. Even in centers I'm working, we don't use a DEXA for identifying a metabolic bone disease. Number one reason is that operational feasibility. It also needs a radioactive. Then more importantly, we don't know what's the normal value of bone mineral content or bone mineral density depending on the gestational age. So sometimes in neonatology, that's why it's there are lots of difficulties in trying to say whether 26 weeks bone mineral density compared to somebody with 32 weeks, how do we interpret? So therefore, still there's a limitation in the widespread use of DEXA in clinical practice. Similarly, something which may be feasible is the quantitative ultrasound. So quantitative ultrasound measure both the mineral content and the organic matrix in the bone. Compared to DEXA, it may be feasible in the NICU without exposing to radiation. It is inexpensive. What does they do is it measures the speed of sound and the bone transmission time. Again, just like DEXA, that the value is very variable between the gestational age and the birth weight of the baby. The speed of sound, so when they have done is that the speed of sound tends to decrease with the age the gestational age advances. And in certain studies, it has been shown that the speed of sound correlated with the calcium and phosphorus and vitamin D levels. So it may be one thing coming on the horizon, but not yet prime time to be used right in the NICU. Second important reason is that the probes used for this for this quantitative ultrasound are not readily available in the NICU population. So that's another thing. Even though you may have heard in the adults, in pediatric population, both DEXAs and quantitative ultrasounds are more commonly being used, but its utility in the NICU is still in the very, very early phase. So those are the screening and diagnostic parameters. So we look at the screening of metabolic bone disease because prevention starts from screening and identifying before. So there's a wide variation between clinicians which thing to choose, right? So this was one of the study which was published as a frequency of preliminary metabolic bone disease screening test among 177 responders. You can see about close to 90% of the people who had responded used calcium phosphate alkaline phosphatase as your primary screening tool. And then the rest of the things are pretty low. Then second question is, how do you test to monitor the progression of if you already have seen metabolic bone disease? Then you can see it ranges from the top 3 common calcium phosphate as well as alkaline phosphate to X-ray, vitamin D, and parathyroid hormones. As you can see, this was back in 2014. So parathyroid hormones was about quarter of the people are using it. Vitamin D in about little more than half, right? But the rest is about 70% are still using the routine calcium phosphate and the serum alkaline phosphatase. So given that, we have lots of this, where we to start? So the suggestion is that start screening between 4 to 6 weeks of age. If you have a very small baby, you're dealing with, less than 25 weeker, people start little early, between 2 to 4 weeks of looking at those parameters. First screening test is calcium, phosphate, and alkaline phosphatase. Look, are they normal number? If they are normal, then repeat within every 1 to 2 weekly. If they were abnormal in the form of high alkaline phosphatase or low phosphate, then the secondary screening parameters can include your parathyroid hormone, tubular reabsorption of phosphate, vitamin D, and X-ray as needed. So if you have the results of this PTH and TRP and vitamin D comes back, and if you have elevated parathyroid hormone with low TRP, that you are dealing with most likely calcium or vitamin D deficiency. Just coming back to the original presentations. However, if you have a normal PTH, but baby still has low phosphate and tubular reabsorption is really good, that means the baby has got likely phosphate deficiency. You might need phosphate and vitamin in such situation. So this will be a take home, is like screen somewhere early and then do the primary, what is available in your unit. And if still not working, then go to the secondary screening parameter. So next come to how can we prevent or reduce, because, number one, so we cannot 100% prevent MBD. That is understood. But can we reduce to a certain extent? Probably answer is yes. And most of them has to do with the nutritional strategies to begin with. Early aggressive enteral nutrition, right? So when we provide aggressive nutrition, when we mean that start early, don't keep the NPO from the day one. It's extremely important to start early enteral feeding. Even if the baby is ventilated, starting with trophic feed is extremely important. That improves the absorption and subsequent feeding tolerance. Second thing is fortification of breast milk is extremely important in this high risk category. So traditionally, people start fortification once it gets to about 140, 150 mL per kilo of full feed. But now what we are suggesting is start fortification a bit early, as you get close to about 80 to 100 mL per kilo per day of your enteral feeding. Third is provide the optimum nutrition. So calcium, phosphate, vitamin D from the beginning. And important thing is always ensure the optimal calcium and phosphate ratios. Because if you give too much of calcium without giving phosphate, or too much of phosphate without adding a calcium, it does not help in absorption of this calcium and phosphate in the body. Therefore, the optimum ratio is set somewhere between 1.5 is to 1.7 is to 1 of calcium and phosphate. So relatively higher calcium ratio compared to the phosphate. So that is another thing. When you are giving a lot of these things, not improving, we always have to go back and check, am I giving an appropriate ratio of calcium and phosphate? And last but not the least, decrease the duration of total parenteral nutrition far as possible. So this was one of the study. I mean, it's a quality improvement project from Chennai. They looked at by this nutritional intervention, can they reduce the metabolic bone disease? So their baseline metabolic bone disease prevalence in the unit was about 35% in this group. So by the intervention, what they have really looked at was adding HMF by day 14, adding HMF to EBM once the feeds are tolerated to 100 mL per kilo, optimize the enteral calcium and phosphorus intake, and start adding calcium and phosphorus in TPN from day one. Actually, they went in a step-by-step process over 3 years period, and they were able to reduce from 35% to as low as 17%, and they were able to sustain. So meaning that still even in, it's possible in your unit. And it's a very nice paper. It's published in BMJ Quality. And the challenges what they have faced, trying to bring to this, the group of people working there and trying to get those fortifications is extremely important. So that is actually doable and preventive. Other non-nutritional stuffs are review medications. Sometimes, when you go for rounds, we realize babies on diuretic for long and long and long. If they don't need it, remove those. It might be useful in the acute phase, but after 2 or 3 days, if it doesn't need to be continued for week and week of diuretics for BPD or any other conditions. Similarly, steroid exposure can be minimized. Third thing is support daily passive physical activities. So there was studies which has looked at passive range of motions and joint compression performed maybe about 5-10 minutes a day for about 4 to 8 weeks have shown to improve bone mineralization, both in, when they assess by the ultrasound and the biomarkers. So that may be another thing. Sometimes we see a baby tightly bundled, have no room for the baby to move around, right? So that may be another thing. And also special handling precautions. I mean, this was one thing we normally put in our unit for babies who are very high risk for metabolic bone disease or they started showing signs. We'd say, just to remind people when we are handling, whether putting IV lines or trying to change from one position to another position, have 2 people trying to move the baby rather than one doing it, just to prevent fracture in those situations. So in terms of nutrition, as we had talked about it, there are various scientific society have developed how much calcium to be given, how much phosphate to be given. As you can see in the first week of life, if the baby is on TPN, for some of these babies, you might need about 40 to 120 milligram per kilo per day of calcium, which to be added in if the baby is on TPN. Similarly, phosphate, if it is available to add, the practical challenge we often face is individual phosphate without electrolytes are not often available. If you need to add phosphate, you need either sodium phosphate or potassium phosphate. But on day one, we do not provide any sodium or potassium in these babies. So it might take about 3-4 days before you start adding the phosphate in your TPN. That was a practical challenge. Certain units or certain countries have used something like a glycerophosphate. If it is available, they can be added in the TPN. But more important for today's talk is about those who are on, did I move a slide? Oh, yeah, enteral nutrition, right? So as we remember, the unfortified breast milk, the baby who are getting roughly about 160 ml per kilo, unfortified breast milk, you get roughly about 37 milligram per kilo and phosphorus of 21. So they are not sufficient to prevent even you get 200 mL per kilo of breast milk in this baby who need definitely a high intake, they are not going to be sufficient. If you use a fortified human milk, they reach to the what is recommended. Anywhere between 150 to 200 milligrams you can easily achieve if you have fortified human breast milk. Phosphorus, similarly, you can achieve, and vitamin D, right? So here, fortification is extremely important, just to reiterate what we have said. Secondly, as we talked about, preferred ratio of calcium phosphate in either enteral or parenteral, try to achieve between 1.7:1 if possible. So there was a questions about how much vitamin D to supplement. I think this was a pretty nice study from India. When they start supplementing vitamin D, 800 international unit daily, you can see that severe vitamin deficiency in 800 international units were lower compared to those who are getting only 400 international units, right? So you see here. However, this is in the serum, right? But what happened to the bone mineral content? When they look at the bone mineral content and bone mineral density, whether you are on 800 or 400, there was no definite on the bone. So the number-wise, it looks good, but it did not do much on this. So I think that also brings to the point of, having adequate calcium and phosphorus supplementation for this extremely preterm baby is essential. In terms of management, so this is what we do practically, I would say, because the first and foremost, when we do this lab test, first test we see is the low phosphate. Calcium is normal. Alkaline phosphate is maybe normal or elevated. So in those situations, knowing that baby has not got adequate phosphate from the TPN from the first week of life, and the enteral fortification takes longer time, so they always have deficiency in phosphate. So we tend to start with a small amount of phosphate to begin with. And then we check it and still not improve. That is the time when we see the secondary line of investigation, such as parathyroid hormones and the TRPs are being done at that particular time. So that may be a practical you might have to start because we have to look at. And if they are already having a florid evidence of metabolic bone disease, as we said, by the time you have got PTH and TRP comes back, we start optimizing calcium if the PTH was high and they have low TRP. And we also optimize the vitamin D at the same time. So when we say optimize, basically, normally fortified EBM fed babies get somewhere between 600 to 700 international unit of vitamin D already. And we normally additionally add 400 units of vitamin D for all babies, irrespective of whether they are fortified or not. If they have normal PTH and high TRP, then we just add the phosphate at this particular group. I think we have seen this slide, just to reiterating that overzealous use of supplemental phosphate can have, if you don't take PTH and just keep supplementing phosphate because your phosphate keep low and calcium being normal, that can be dangerous at times. So with the first line, if you're not working and your phosphate supplement is not working, go back and make sure at least you are not dealing with hyperparathyroidism and causing all this bone demineralization happening. So that's the take home message. And this was one of the other slides. So endocrine perspectives are a bit different than the neonatal perspective. This was the, like the same like hypoglycemia guidelines, right? How the neonatologists look at versus the endocrinologists look at, sometimes different. Similarly, metabolic bone disease, by the time you are not doing well, you consult the endocrinologist, and that time they might suggest this thing. But it's quite similar. You have a raised ALP, low phosphate, or normal or raised PTH. So they suggest to get vitamin D estimation. If PTH was rise, likely calcium and vitamin D deficiency, that's when you start calcium supplement, optimize vitamin D, stop phosphate supplementations if prescribed, and ensure those ratio between the two. If it's a normal PTA, slightly phosphate deficiency, then you add extra phosphate, but make sure that you have the same calcium phosphate ratio. In such situations, if you're adding extra phosphate, you might also have to supplement extra calcium, despite your calcium being normal. So that's the second take-home message. When you're supplementing phosphate, make sure you have some additional calcium so that you can calculate this, optimize this ratio. And recheck all those things within 1 to 2 weeks to find. This was one of the clinical reports from AAP. If you already have rickets, the same thing as we talked about, optimizing your nutrient by increasing fortification. Make sure you have optimal calcium and phosphorus. Check your vitamin D, then recheck your radiograph. So that is where importance is. When to check, you have a fracture, now you start treatment. Wait for at least 5 to 6 weeks before you see all those things are getting better. And advise caregiving team about cautious for handling those infants. As we said, warning sign at the bedside is extremely important, and limit all those things. And other practical tip I would suggest is look at what is available in your region. What kind of calcium preparations are available? How much elemental calcium is available in those compositions? What phosphate supplementations are available? This is what some of the things we use. We have sodium phosphate, we have potassium phosphate, and calcium carbonate. Those are the 3 available things in the NICUs, but I'm sure various countries will have different compositions. So always nice to go back and check, are we giving too much of calcium or not? So this brings to my 4th poll. Okay, 58% calcium deficiency. Yeah. So definitely high PTH, low TRP often goes in calcium. So that's one thing to take home. Does it have any long-term consequences, the metabolic bone disease? This is again, there are not many studies who have followed many of these babies who had metabolic bone disease. Most of the NICU sees right at the discharge. Some of the babies who come for follow-up, because calcium phosphate estimations are not often regularly done. But some of the observational studies have shown that infants with metabolic bone disease may have enamel hypoplasia and a high risk for dental caries, fractures, as we have seen, even in the NICU, myopia, and against the role of astigmatism and dolichocephalic head, together with deformation of palate. Because many of our babies had a very group high arch palate by the time they live with those feeding tubes and the soft palatal bone. So those are a few long-term consequences, and a lot more studies to be done in this aspect. So to conclude, I think it's clear that adequate enteral calcium and phosphate intake is essential to prevent metabolic bone disease. And always remember the appropriate calcium and phosphate ratios, and they have to be maintained, especially when we start adding extra calcium and phosphate. Screening and early identification is extremely important to prevent complications such as fractures. And there are significant knowledge gaps in terms of screening, prevention, and long-term sequelae in neonates. Thank you so much.
Thank you so much, Amuchou. It was an exhaustive lecture. Now we have an interesting discussion coming up. I invite the moderators for the day, Prakash Venkal and Amanpreet, to kindly take over.
So, it was a wonderful lecture, sir. you have touched all the points. So during our residency also, so we did a sort of research on this topic, a forgotten topic, because we talk about ROP, we talk about hearing screen, but we sometimes miss this important disease which is happening in our NICUs. So osteopenia is a forgotten disease, but we should take care about that. So there are few questions which have come in the chat box, but there are some contextual issues here, sir, which I would like to discuss. At what age, we work in low and middle income countries, so we have a lot of IUGR babies, preterm IUGR, term IUGR babies. So what is the gestational age cutoff which should be used for screening these babies for metabolic bone disease? So any take on that, sir?
Yeah, that's a very good question, especially starting at that. So I think, especially if you have a SGA baby, I would say about 34 weeks or less probably is the right, because as you see physiologically between 32 to 36 weeks, but the peak is around 34 weeks is where all those transfer of calcium and bone, phosphorus that happen. So I would say below 34 weeks, definitely I would suggest, and especially less than 1500 gram babies should be the one you should be screening routinely for this thing.
The other contextual question is at what age we should start screening? Like you have mentioned at 4 weeks. So in some babies, like in TPN received babies, we can start a little early, or it is still at 4 weeks we can start?
So traditionally what happens is that, so once the baby is on, so full enteral feeding and 45, normally by about 2 weeks, we get babies on full feeding, right? So once we fortified, actually within 2 to 3 days after the full fortification, we check the calcium and phosphate, not alkaline phosphatase. So we check calcium and phosphate. Sometimes some of the fortification, depending on what kind of fortification, as you have seen, whether you have a breast milk fortification, multi-component fortification, or is it just a preterm formula fortifying? And I think lots of literature have come up. They are quite good either way in terms of weight gain, right? So I think what we do is within 2 to 3 weeks, 2 to 3 days after fortification, we take. So that will be around 2 to 3 weeks of life. And similarly, here, what we do is we have a newborn screening, second newborn screening between about 3 to 4 weeks. We try to combine sampling at the same time, again, just trying to club most of those things. So I would say between 2 to 4 weeks, you can start looking at it depending on the situation where you are. Because I think if you have a 34-week baby, trying to screen by the time they might have been discharged from the hospital, so before even testing. So I think that may be the reason I would say.
And sir, regarding the cutoff levels, you have already told that there is some variation in various cutoff levels like phosphorus and alkaline phosphatase. So in your unit, you are using phosphorus at a cutoff of less than 5.5, I think, milligram per DL. So we use milligram per DL here,
Okay.
and alkaline phosphatase at more than 800 international unit. But in some countries, the phosphorus is taken at less than 4 milligram per DL. So why this variation is there?
So that's another, differences in the, in the first week of life, when you really check phosphorus level, most of the phosphorus, what we see are very low. So somewhere as low as 4 to 5 milligram per deciliter. So depending on, if you are checking in the very early, before even you have start supplementing, either in TPN or even the nutrition, that's why when we looked at the cord blood samples, and then when we look at the blood samples, which was done for certain other indications, when they look at the phosphate level in the first week, they are somewhere between, I think, 4 to 6 milligram per deciliter level. But then by the time when they get, after full feeding, we start looking at cutoff at, that 1.8 millimole, this is about 5.6. That's when they start seeing more of those babies. Yeah.
Just to increase the sensitivity, I think. That's all.
Absolutely.
Sir. And sir, what to be done in babies with cholestasis, like their alkaline phosphatase is already high. So in that case, only phosphorus level to be taken, or some other parameter like PTH and other things has to be looked upon.
So few things have to look at. I would say when we talk about alkaline phosphatase, it is also, as we rightly say, there are various other conditions where alkaline phosphatase can be high despite having a normal, right? One is cholestasis, right? Similarly, when you have a zinc deficiencies, you can have a higher alkaline phosphatase. But surprisingly, most of our babies, what we see in the NICU are somebody who had been given steroid. Despite having a severe bone disease, their alkaline phosphatase is either low or normal. And sometimes we say, oh, the baby doesn't have bone disease, but actually, so if the baby has received steroid, just be cautious about interpreting alkaline phosphatase in those situations.
Okay. Thanks. Over to Prakash, sir, for next.
Thank you very much, Professor. It was a wonderful talk. Everything was covered very well, and had a good, understanding of how the fetal accreditation as well as the neonatal part of it as the baby grows, and mainly, looking into the wider aspect of how to screen these extreme preterm babies. I have few challenging, issues which we face here. One is when we have these extreme preterm babies, we all aim for as early as enteral nutrition. At the same time, the TPN is going on. But for some or the other reason in India, we tend to have a difficulty in, attaining the full feeds or reach to full feeds by 4 to 6 weeks for various factors. One of the commonest thing is, feeding intolerance and necrotizing enterocolitis or suspecting necrotizing enterocolitis. Then we are, kind of a situation where we have to continue TPN. And we also stop feeds for a couple of days for probably around 5 to 7 days. Now, when you're trying to adjust this calcium and phosphate during this period, we have a lot of irregularities. One is trying to correct the phosphate, another is trying to correct the calcium. So I know these are the challenges which are being faced by most of the NICU, doctors who work. But how do you deal with those situations? And my second question is, in babies, sometimes if we are not able to establish feeds, or if we have established feeds for whatever reason, we may have to start hydrolyzed formulas. Then it is being shown that when we start using for long term, you tend to get phosphate deficiency in those babies. These are the challenges where we faced. I think the rest of the things were quite nicely presented. So I would probably like to take a few information from you.
So let's start with the first one about when babies on TPN, how do we get those optimized in calcium and phosphate, right? One thing is clear that the solubility of calcium and phosphate varies depending on the pH of the formulation. One thing is that, so we try to achieve with the babies on full TPN, try to get about 3 to 4 grams per kilo per day of proteins. So having a higher amino acid actually does help in the solubility of those calcium and phosphate, so that they prevent the precipitation, because we also see sometimes trying to manage the ratio, but sometimes overzealously, because the low phosphate people try to reverse the ratio, having a more phosphate and less calcium. And then you said the TPN pharmacist like, oh, the formulation is precipitated. So we try to look at those solubility factors by increasing at least the amino acid if possible. That is one way of looking at it, and try avoiding those reverse ratio on the TPN. So as long as when we start to begin with, as I said, first day TPNs always have calcium, because calcium can get from calcium gluconate and proteins. But day 4, day 5, by the time you start wanting to add a little bit of sodium and potassium, there we try to add the phosphate a little bit, because we can get sodium phosphate or potassium phosphate. So that with but I do see that sometimes people see metabolic acidosis in the babies and they want to give little more acetate, because again, they come from sodium acetate and potassium acetate. The first formulation we say is try to get at least start giving a little bit of phosphate to begin early rather than trying to correct the acidosis, because kidney is immature. They are going to excrete whatever bicarbonate is going to come out. But phosphate, if you don't supplement early, when you have a room to add phosphate, then they are going to deplete the phosphate for a prolonged period of time. That's going to be bad. So I would say start as soon as possible. When you have some amount of phosphate can be added, add in those TPNs, and that might help in solubility issues. Second questions on the hydrolyzed formulation. Yes, certain babies don't tolerate milk. That we do see there, and I would say some of this either partially hydrolyzed or extensively hydrolyzed, like Nutramizan. They have very less amount of phosphate, and most of those babies needed extra phosphate supplementation in those situations. And so we closely monitor their phosphate level in those situations and add supplementation if they were deficient in the phosphate in those babies. This might also apply to, I would say, babies who are on donor human milk, because they don't thrive and they have very limited amount of calcium and phosphate. So I would say this is another thing to look at if babies are not thriving well, and then your metabolic derangement is happening. Just unless you check your levels, it's difficult, and then add accordingly.
I have one more question to conclude. Can we add calcium in TPN and phosphate as separately in another infusion with dextrose?
Good question.
In order to prevent precipitation.
So, Dr. Prakash, what we see is when they add together, actually, I don't know, I mean, depending on the acidity of the TPN, they don't precipitate. It's only when we give more than what is required. Therefore, you know, the amount of calcium and phosphate what we give in the first week on TPNs are minimum. Just so not like, you know, as I said, like, you know, somewhere between 40 to 80 instead of, you know, 120 to 200. So with that amount, I think we were able to get it, but dextrose and calcium can go together, but I'm not sure the phosphate, the volume is so small. I'm not sure. I mean, we have not done,
because that was a thought process in some of the, you know, people around here, whether we can kind of separate and see whether that can be reduced. But
right.
Yeah, as you rightly said, that you know, this is what commonly is practiced. What you said. I think there are a few questions we can take. You want to go with the first question, Matthew?
Yes.
How many minutes?
So there's around 22 questions right now. So we can start with the first question, sir.
Yeah.
Sure. Yeah. So it is a question from Dr. Livet Flores. Does the calcium concentration not vary if it is immature or mature breast milk?
So as we saw in the literature, they are quite similar. I mean, the variations can be only 1 to 2 milligrams. So that's why anywhere between 23 to 28 milligram per deciliter is in both mature
shown
and
in the table also. Yes.
Yeah.
Nicely shown in the table. The second question was from Dr. Senthil. Is phosphorus correction needed like calcium correction if serum phosphorus is too low? And if so, what is the dosage? Okay.
So if you have a low phosphate, so basically if the formulation is available, because as I said here, we have phosphate solution, which is sodium or potassium phosphate solutions. We correct it, but remember that, I mean, every country has got different formulations. 1 ml, what we have has got 3 millimoles of phosphate. You know, 1 millimole is about 4 milligrams. So I had to always convert in the milligram and a millimole. So generally, if you have a low phosphate, so we start with the small doses, because phosphate absorption in the intestines are pretty good. Even in preterm, anywhere between 80 to 90% get absorbed. And so once we start phosphate supplementation, within about 2 to 3 days, we recheck. We don't wait for a week because you don't want overshoot or undershoot. So that will be the answer for you, Dr. Armugam.
And the next question is there any difference between mother milk derived fortifier and cow's milk derived fortifier in prevention of metabolic bone disease? So any difference between human milk based fortifier or cow milk based fortifier?
Very good question. I'm not aware of any comparative study between those two groups. Most of the fortifiers we use here are usually cow's milk based, but remember, cow's milk does have a excessively high calcium. So always have to be remember that was the one thing, but I'm not sure about the formulations like a human milk based fortifier, how much calcium and phosphate, because I'm sure they'll be lower because mother's milk does have a very low calcium, right? So probably that may be one thing to look, but I don't have a specific answer to that.
Next question was from Dr. Levitt. If a baby has elevated alkaline phosphatase, but with normal calcium and phosphorus, without being able to carry out the other studies, can they be supplemented with calcium and phosphorus? So only diagnostic test they have done is elevated alkaline phosphatase. Elevated alkaline phosphatase.
Yeah. So if you have a normal calcium and phosphate and the baby is on optimized nutrition, there are other reasons for high alkaline phosphatase. Some of those conditions we need to identify, because if the baby was not getting enough calcium and phosphate, then you probably have to optimize it. But I think in this situation, I would say look for isolated high alkaline phosphatase conditions like hyperphosphatemia or something like that. Yeah.
Okay.
Next question, sir, you can take.
Okay, sure. This is a question from Wasim Khan. Why are we using phosphate supplement initially without doing PTH, as it will further increase PTH level and more demineralization?
So that's very good question. So as we see, we talk about practically, right? So even if you have a low phosphate levels right now, and your PTH, depending on, takes weeks for the result to come. I'm not sure in India, how long does it take to get? And these are batch kind of thing, any hormonal testing. But one thing is that knowing that phosphate supplementations are pretty, or I say phosphate depletions are very common in preterm babies after birth, because we have not started giving them from day 1, day 2, day 3. So their depletions are more common than actually what the baby has. So therefore, I think in the beginning, while you're waiting for all those days, I think it's probably reasonable to start a little bit of sodium phosphate or potassium phosphate supplementation while awaiting. That's why it's like, if in the best of scenario you have the test, yes, if you can get on the same day, then you can decide about what you want to give, calcium or phosphate. But practically, it's not feasible even in the the best centers. That's why we tend to start with that one and then wait for the subsequent testing.
I think the next question is also the same, Ravi Agarwal. We'll skip that and we'll go to the next question by Jubara, sorry. What X-ray you used, wrist X-ray or skeletal survey, and how frequently do you do screening X-ray?
So X-rays, either the wrist or chest X-rays are often the site where people look at it. But for the screening purpose, as I said, generally people recommend somewhere between 5 to 6 weeks of life. But I think if you are doing X-ray purely for the metabolic bone disease, I think somewhere if you have to do will be about 5 to 6 weeks is what people have recommended. That's the time they appear. Doing early before the demineralization is less than 20 or 40%, you may not find anything, and you don't want to expose the baby to a multiple X-ray for it. So that's why I say biochemical parameter followed by the X-rays would be the way to go.
So the next question is by Spriti Menon. Does hyponatremia in the absence of diuretics, steroids, or caffeine with normal levels of calcium, phosphate, and vitamin D levels and supplementation also contribute to metabolic bone disease?
Just a plain hyponatremia, I don't think it causes, because most of the things are to do with calcium, phosphate, vitamin D related things. Yeah.
Next question by Lou. After we started the treatment with calcium phosphate and vitamin D supplementation for MDP, how do we monitor and taper off supplements once the condition improves?
Good question. So generally, once they are normalizing, so even after baby goes home, so you try to continue those calcium. So basically what you do is optimize what you're getting from the nutrition, whether a baby is on 45, or is it just the extra calcium and phosphate you give separately? If they are normalized by the time they get to a full term, and then people have, the post-discharge follow-up is very limited information in the literature. Some suggest up to about 40 to 44 weeks post-conceptional age to continue. Some suggest up to about 3 to 6 months, depending on how severe the illness was. So I think it will depend on what clinical pictures you have, what radiological finding you have, that will help you in tapering. So it will become very individualized in those situations.
Okay, Amarpreet, can you take a few questions, please?
Next question is from Dr. Ravi Agarwal. So he says that we give fortifiers with breast milk early and add vitamin D at 400 international units per day. So in some extreme preterm infants, they have seen that the babies have got very high vitamin D levels. So what is the reason for that? And should we give less vitamin D in these babies, as fortifier also contains vitamin D?
So there are various formulations in fortifier, so that's why you have to really look at. So if the baby was like the 1 kilo baby getting 150 ml per kilo of breast milk with fortifier, they roughly get about 200 units. But the same baby, when they get to 2 kilos, 150 ml times 2 is about 300 ml. By the time they get sufficient or more than enough amount of vitamin D, they receive from the fortification alone without extra supplementing. So I think there's a saying in the sense that calculate, you might start with 400 to begin with, extra vitamin D plus fortification. But if the baby is growing and, by the time when they get to 2.5 kilos, it'll be too much from the fortification alone itself. In that case, you might have to just cut back a little bit.
Fortification is stopped after some time, 40 weeks. We usually.
That's correct. Right. So generally before they go home. Yeah.
As soon as the baby starts taking breastfeeds, so fortification.
Absolutely. Absolutely.
So next question is from Dr. Ramachandra. What is the association between osteopenia in preterm neonates and the myopia outcome in later life?
It's one of those studies have shown that basically when the bone has to grow during this period, and if they are not, so I think the orbital size probably is not growing despite baby is growing, so your eyeballs become longer. But there are not many long-term studies have seen in such babies, but slightly higher risk of myopia. But the question is it just from the metabolic bone disease alone, or just being born premature? Because many of our preterm baby who had ROPs, they tend to have myopia. So there's a confounding factor in that group too.
I think the next question is from Dr. Khurshid Alam. I think it is the same question, like if with EBM and HMF, if daily requirements are taken care of, then do we need to supplement with extra calcium, vitamin D syrup or drops? I think you have discussed this before.
Yeah.
Next question is from Dr. Rani Bashir. How would you approach if PTH is low, phosphorus is low, normal, calcium normal, and alkaline phosphatase is 770, and alkaline phosphatase is showing a rising trend?
Okay, so looks like in this particular situation, you probably have a low phosphate deficiency. So in such situation, probably supplementing a little bit of phosphate might work.
Yes. Next question is from Dr. Lua Zhang. How much vitamin D to start if vitamin D level is low, and how long do we continue?
So the vitamin D recommendation varies between various bodies. For example, AAP, American Academy of Pediatrics, suggests about 400 units, but the European Society, like ISFGAN, recommend up to 1,000 units. So anywhere between 400 to 1,000, but not too much more than that. So that's what I would keep the range.
In our Indian, I think guidelines, they suggest to give 2,000 international unit daily. In deficiency states, I think. If you have vitamin D levels less than 10, I think 10 nanogram.
Okay.
So Wasim Khan has answered a question whether we should continue phosphate supplement in babies with low phosphate, high ALP level, and high PTH. I think you have discussed about that.
That you have decided.
Next question is from Santhia. So she has asked if phosphate is low, like 1.5, associated with high PTH and low TRP, still we can supplement only calcium, or should we treat with low phosphorus by giving phosphorus supplements, as phosphorus is very low?
So this is a very good, scenario we often find in the bedside, because you start with low phosphate, you start supplementing phosphate. Then by the time the result came back, despite having a phosphate supplementation, phosphate keep going down. In those situations, I think here the primary pathology is the hyperparathyroidism causing bone demineralization. And this is like a pure calcium deficiency. So calcium in the vitamin D optimization might be the best thing to go off the phosphate, and check after a week and see how the things get improved or not.
Next question is from Dr. Ravi Agarwal. If PTH is high with normal calcium but low phosphorus, so what should we supplement? Only calcium or both calcium and phosphorus? I think it is the same question.
Same question. Yeah.
So next question is from Dr. Meda Goyal. In human milk-based fortifiers, like the calcium and phosphorus contents are quite low as compared to bovine milk-based. So should we be concerned and give additional supplements?
Yes.
I think so.
Okay. Sir, you can ask the next question.
Sajad has a question. Sir, can fractures occur even after the weeks of correction of hematological diagnostic parameters like alkaline phosphatase and phosphorus of MBD?
Yes, they can occur. So the mineralization, as you say, you might see the screening parameters, but the bones are pretty weak. So depending on what kind of handling we do, some babies, even with the soft bone, when you're trying to get the IV, like peripheral IVs, you may have seen, we have seen some babies have crack on those. Most of those are not displaced fracture. Most of them are like a hairline fracture we have seen. So yes, answer is can happen.
Rohit has a list of questions. I think few are answered. I'll just go through the questions. After what age in the follow-up can we stop routine monitoring and stop supplements, which has been answered. At our place, routine calcium supplement has 2:1 ratio of calcium phosphate. Would you advise adding extra phosphate separately as a routine, even if I'm not sure what it is, even if phosphate is not there, I think. So
osteopenia prematurity, I think.
Osteopenia prematurity, yeah, okay. Right, yeah. That's one question. When and in whom to consider for screening for complications for supplementation like nephrocalcinosis and other complications should be carefully about. In bigger babies like more than 34 weeks or more than 1.5 kgs, when to stop supplement? Is it wise to blindly supplement and can be overdoing with supplements? in babies on TP1, should we supplement calcium and phosphate separately as chances of precipitation? Should we do, like, for example, 12 hours of calcium and 12 hours of phosphate? Any role of cysteine addition and altering TP and pH to improve solubility? I think few are answered already. You can take some of the questions.
So one of the questions I think is the nephrocalcinosis, right?
Yeah.
So I think when you have overzealous supplementations, that can also cause a hypercalciuria and can cause nephrocalcinosis. So generally extremely low, but with babies who had used a diuretic and a lot of supplementation, we routinely do an ultrasound kidney somewhere around 36 to 38 weeks, just to see whether they have developed any nephrocalcinosis. That's one thing we routinely do. Other thing, I think we talked about the when to stop supplement. TPN, I think we did answer about the solubility product. Yeah.
There's another question from Santhia. Potassium phosphate as TPN. So we have to give it in separate infusion or can be given along with the calcium.
Sorry, what's the question?
Potassium phosphate as in TPN, I think. So we have to give it in a separate infusion or can be given along with the calcium, which you have already.
Okay, so if it's in the TPN, you can actually provide all of them together.
Rohit, better phosphate supplement preparation for TPN.
Is it sodium or potassium?
Yeah, sodium phosphate or potassium phosphate, I think probably is that.
That's right.
Okay, Raj Gupta, how reliable is phosphate level soon after oral supplementation, as you may get falsely high or normal phosphate levels?
So generally we do about 2 to 3 days after start supplementation just to make sure they are not overshooting, because phosphate, as we said, absorption is pretty good compared to calcium alone.
Okay, I think
when to Dr. Rohit has asked again question, when to expect radiological response?
you also
Around 4 to 5 weeks.
Dr. Udoka has asked, is there any role of fish oils in these?
Fish oil probably to do with vitamin D rather than calcium and phosphate, right? But, yeah.
Then next question is from Santhia. Phosphate level is 1.6. PTH is high 123. Alkaline phosphate is 760. I think this calcium is 9. So should we add phosphate in this situation?
So, this is the situation where we as a neonatologist who are so used to calcium, not looking at phosphate happen. That's the reason why I circulated the slide again and again to get to the point. If you have very high parathyroid hormone and low phosphate, and if you already have, then you're dealing with calcium problems, calcium deficiency or vitamin D deficiency issues.
So vitamin D levels has to be seen, I think.
Right? Absolutely.
I think this is the last question.
Jubara Allah, when you consider genetic study for preterm infant with bone fracture, it's metabolic disease versus osteopenia, I think OI, especially in areas
imperfecta.
So any imperfecta, yes. So any, especially in area with high consanguinity.
So I think when you see a osteogenesis imperfecta, right? So it doesn't involve only one bone alone. There are multiple sites and they might start a bit early. Some of them have fractures in utero, some of them present later. So, but I think if you're starting very early fractures, definitely, because metabolic bone disease does not appear so early in the first week or two. Most of this takes time. So I would look at the history and physical and see what are the other associations in that, apart from just being a fracture alone in this situation.
I think if there are a few questions from the audience, we can take 1 or 2 questions. If somebody is interested to ask. Or any comments? Okay, Manoj, over to you.
So thank you so much, Dr. Prakash and Dr. Amanpreet. That was an exhaustive discussion you have moderated. Thank you so much for sparing your time. And then my heartfelt thanks to Amuchou. This is a very detailed lecture we had on a topic not so well discussed. So it was a great learning experience for most of us. Before we close, we have the Secretary General of National Neonatology Forum India, Dr. Surendra Singh Bist. I would request him to make some concluding remarks before we close.
Thank you, Manoj. And thanks, Professor Amuchou, Suraisha. And it was so nice, as Aman said, it's a forgotten topic. It's a topic which was, we do in the hustle and bustle of a busy NICU and trying to save babies when the babies are coming out. You are busy with another sick baby, looking after another ventilated baby, and you are just wanting them to go out and go away. And they are actually growing. And as you rightly said, we need to look into this. And I think Aman has rightly said, this is something it gets forgotten. And the way you spoke, the kind of the diagrams which were there, the 4 or 5 liners which were there in each slides, made it so easy for a person like me also to understand it. And the kind of questions which were coming later about the calcium, phosphorus, PTH, again, in various permutation and combination, actually conveys that most of the people got the hang of what they are going to do when they are actually confronted in such a situation. So they know at least now that they have to do a calcium, phosphorus, PTH, and ALP to know metabolic and not jump into directly into DEXA scan or an X-ray, doing repeated X-rays. I think that said so. That was a highlight of the day today. And I think almost 200 people were there from across the world who attended it and interacted. So nice of you, Amuchou, and our moderators, Prakash and Amanpreet. Amanpreet is a dear younger colleague of mine. I actually take him as my quite a younger brother. I sometimes call him just Aman and not even Aman. Okay. Prakash, it's a good friend. And I see Dr. Sheila Mathai here. Namaskar, madam. And Dr. Prakash Bankoti, and there's Murali Raj also. And in the audience, I see so many doyens of our NNF actually looking and listening. Vandana Negi, Poonam Sidana, and there are so many of them. And I was so many people actually listen to it, and the kind of response in our Learn to with Legends is coming. And I think Manoj must have asked you for some more thing to give apart from the lecture. We want you to contribute to give us some written thing also later, so that we can have a collection of a written lecture also. Though we have a video collection which we want them to be displayed and shown in our video collections, which is being done right now. But we want a written kind of thing so that it is stored in a collection also. With these words, I thank you, Manoj, Amuchou, and everybody.
Once again, thank you all. It was a wonderful session. Thanks to the excellent faculty and the moderators. We had a lively discussion. Before we close, I would like to thank all the respected delegates who have been with us for the last 3 years for the series. It was a wonderful learning experience we had together. But this is not the end of it. We have the next lecture on a very common popular topic that all of us who take care of babies do. The neonatal resuscitation protocol, the 2023 aspects being discussed on August 17th. So I would invite all of you to join for the next session as well. Until then, we say goodbye. Thank you. Thank you.
Thanks a lot.
So much.
Thank you.
Bye.
Thank you. Thank you.
Take care.
Have a good day, Amuchou.
Thank you.
Thank you. Bye-bye.
Bye-bye.
Thanks. Okay.
Bye, Aman and Prakash.